Hi, my name is Claire Blanchard, and I'm a fourth-year pharmacy student at Drake University in Des Moines, Iowa. Today, I'm going to be discussing a study that looked at Baclofen for alcohol dependence in patients with liver cirrhosis. I'm going to be talking about some background on alcohol dependence and health consequences, the reward pathways of the brain, and Baclofen pharmacology. I'll provide an overview of previous studies done on Baclofen for the treatment of alcohol dependence. Then I will get into a randomized double-blind study about Baclofen use for maintenance of alcohol abstinence in alcohol-dependent patients with liver cirrhosis. I'll follow that up with applications to practice. According to the World Health Organization, in 2010, 4.7% of the United States was considered alcohol dependent based on DSM-4 criteria. In particular, 6.9% of the male population and 2.6% of the female population. One of the consequences of alcohol dependence is liver cirrhosis. In fact, alcohol is the most frequent cause of liver cirrhosis in developed countries. The World Health Organization reports that in individuals with liver cirrhosis, 60% of male and 62% of female deaths can be attributed to alcohol. This includes any alcohol-related deaths such as alcohol poisoning or motor vehicle accidents. These statistics illustrate the need for effective treatment of alcohol dependence in those with liver cirrhosis, as there is a fairly high association between liver cirrhosis and alcohol-related death. Next, I want to go over a little bit about the reward pathway and how it's affected by alcohol. Upon ingestion, alcohol increases dopamine concentration in the nucleus accumbens. This stimulates the reward center of the brain in a similar manner as rewarding activities such as eating. Since the brain attributes alcohol use with this rewarding sensation, individuals are likely to seek the same feeling in the future. This is part of what contributes to the psychological side of alcohol dependence. Ethanol also potentiates GABA's inhibitory effect in the brain, which leads to generally slowed movements and thought processes. It also lowers levels of glutamate, the excitatory neurotransmitter. In order to counteract this, glutamate activity is upregulated. If a physically dependent individual fails to counteract the elevations of glutamate with alcohol-mediated potentiation of GABA, then they experience alcohol withdrawal. This imbalance of inhibitory and excitatory neurotransmitters is associated with physical alcohol dependence. There are currently 3 FDA-approved treatments for alcohol dependence. Disulfiram disrupts alcohol metabolism and can cause severe adverse effects with even a small amount of alcohol, often leading to noncompliance, and should be used cautiously in liver disease. Acamprosate normalizes excitatory and inhibitory pathways in the brain. However, there is unclear evidence for maintenance of alcohol abstinence. Naltrexone is a competitive opioid antagonist which poses a risk for hepatotoxicity at high doses. The drug featured in this study, Baclofen, is a selective GABA-B receptor agonist which is indicated for use as a muscle relaxant and antispastic medication. It is primarily renally excreted with only 15% hepatically metabolized. This differentiates it from 2 of the 3 FDA-approved treatments for alcohol dependence in the sense that it can be used in those with liver dysfunction. Some common side effects include drowsiness, dizziness, weakness, fatigue, confusion, and headaches. Baclofen does not cause euphoria. The proposed mechanism for treatment of alcohol dependence with Baclofen is via activation of GABA-B receptors to locally suppress alcohol-stimulated dopamine release. This helps decrease stimulation of the reward center. Other studies that have been done. There have been relatively few large studies about baclofen for alcohol dependence. Of the 8 total studies, only 4 have been double-blind randomized controlled trials, and of these, only 2 had more than 40 patients. The usual dose that was utilized was 30 milligrams of baclofen by mouth per day. These studies excluded patients with liver damage, as defined by AST or ALT greater than 3 times the upper limit of normal, or elevated bilirubin. Most of these studies measured alcohol abstinence and craving as an outcome. They found that craving was usually decreased with baclofen administration. It was also noted that relapse was more common with placebo treatment. Overall, there is a distinct lack of studies in patient populations with liver damage, although it is a common complication of alcohol dependence. That being said, the following studies set out to look at just such a population. Published in The Lancet in December of 2007, this study's goal was to determine efficacy and safety of baclofen for alcohol abstinence in alcohol-dependent patients with liver cirrhosis. The primary outcome of the study was the proportion of patients achieving and maintaining alcohol abstinence, specifically total abstinence from alcohol, and cumulative abstinence duration, which is the total number of days abstinent from alcohol. The secondary outcomes were the difference in craving measures between treatment groups. They looked at the Obsessive Compulsive Drinking Scale, OCDS, which is a measure of craving, Obsessive Subscale Score, and the Compulsive Subscale Score. Something else this study looked at was the change in liver enzymes and biological markers of alcohol abuse from baseline. The inclusion criteria for this study were adults aged 18 through 75 years old with a DSM-4 diagnosis of alcohol dependence, a diagnosis of liver cirrhosis, alcohol intake of at least 2 heavy drinking days per week, with 5 or more drinks per day for men and 4 or more drinks per day for women. They also needed an average overall consumption of 21 drinks per week for men and 14 drinks per week for women during the 4 weeks preceding enrollment, where 1 drink is equal to 12 grams of absolute alcohol. They also needed a family member to aid in drug administration and monitoring. Exclusion criteria included severe heart or lung disease, abnormal renal function, hepatorenal syndrome, malignancy, metabolic diseases, hepatic encephalopathy, interferon or corticosteroid use in the past 60 days, treatment with psychoactive drugs, epilepsy, addiction to drugs other than nicotine, and liver cirrhosis caused by other disease states such as autoimmune hepatitis. The study was a 2-armed, double-blinded, randomized trial which utilized patients referred to the medical center in Italy. Once the patients consented, they were admitted to the hospital for 3 to 4 days for histological, serological, biochemical exams, and treatment of any alcohol withdrawal with diazepam. Patients were randomized with 42 receiving baclofen and 42 receiving placebo. Participants were up-titrated from 5 milligrams of their treatment, either baclofen or placebo, 3 times daily for days 1 through 3, to 10 milligrams 3 times daily for the remainder of the 12-week trial. Patients were advised against using drugs with potential effects on craving, such as benzodiazepines or antidepressants. They were assessed every 2 weeks with a review of drinking, overall functioning, difficulties with adherence, and adverse effects. Adherence was measured by pill counts. Patients received 30-minute standardized support counseling at every visit. These are the baseline characteristics from both the intervention and control group because there were no significant differences between the groups. In particular, the average age of patients was 49.25 years old, with 72% male and 27% female, with an average of 22 years of alcohol abuse and an OCDS total score of 26.5 out of a potential 40 points. The average child Pew score was 9, classifying them as Class B. This is used to assess prognosis of chronic liver disease, and hepatitis B virus positive patients represented 15% of the population, and 57% were hepatitis C virus positive. These populations, Hep C and Hep B virus positive, were allowed in the study due to their concomitant alcohol dependence. Both primary outcomes of total alcohol abstinence and cumulative abstinence duration were found to be significantly different between treatment groups, with Baclofen treatment eliciting 71% total alcohol abstinence versus placebo's 29%, and a 62-day cumulative abstinence duration versus the 31 days of the placebo out of a potential 84 total days. There was no significant difference between adherence to therapy or side effects seen. There were no reported dropouts due to adverse effects of either therapy, and almost the same side effects were reported between groups, including headache, tiredness, vertigo, and sleepiness. Figure 3 shows the mean total OCDS score, compulsive and obsessive subscale scores, in both treatment groups over time. In all of them, there's a significant effect of both treatment and time on all three scores. Baclofen was found to significantly reduce craving as measured by OCDS score. At the 12-week period, Baclofen patients had significantly reduced ALT, bilirubin, INR, gamma-glutamyl transferase, and significantly increased albumin. This study concluded that oral Baclofen is significantly more effective than placebo in alcohol-dependent patients with liver cirrhosis at achieving and maintaining alcohol abstinence, increasing cumulative abstinence duration, and decreasing craving. Baclofen was well tolerated at these dosages. The reduction in self-reported alcohol use was associated with significant reductions in clinical markers of liver injury. One strength of this study was that it was double-blinded and randomized with placebo tablets of identical size, shape, color, and taste as Baclofen. They took laboratory measures of alcohol abuse from baseline and throughout therapy to correlate with reported alcohol use. Patients with potential confounding variables, such as psychoactive medications, which may affect craving, were excluded. Statistical analysis utilized an intention-to-treat approach, designating any dropouts as relapses, which may lead to underestimation of abstinence rates. They utilized an ANCOVA model over an ANOVA model to statistically account for potential effects of both treatment and time on the dependent variable. Some weaknesses present in this study include the reliance on self- and family-reported alcohol intake. There may have been some discrepancy between the values that even study parameters of utilizing the highest estimate couldn't account for. There was a relatively low study population, with 19 of the 84 patients dropping out. Dropouts were lost to follow-up, noncompliance, or had worsening conditions judged as due to progression of liver disease and not to treatment. It was calculated that for significant statistical analysis, this study needed at least 40 patients per treatment arm. They had just barely enough when they counted patients they intended to treat, with 42 patients in each treatment arm. There was also the routine psychological support counseling that each patient received. This could have affected outcomes based on how seriously each patient took it. This study shows baclofen as a potential treatment option for maintenance of alcohol abstinence in patients with liver cirrhosis, which is a high-risk population for alcohol-associated death. It is also a potential option for those with risk of drug abuse, as it lacks a euphoric sensation, so it is less likely to be misused for that purpose. It would be ideal to look into optimal dosing requirements to determine whether the appropriate dose would have unfavorable side effects. It is also unclear what the best duration of therapy would be, as there have not been sufficient studies in this area. Should the ideal treatment duration be long enough to induce tolerance, what adjustments can be made while maintaining safety and efficacy? Thank you for your time and consideration. Please feel free to contact me with any questions.